Thank you. Good afternoon, everybody. Welcome to this meeting of the Healthcare and Wellbeing Scrutiny Committee being held on Monday, the 24th of November 2025. For those present in the meeting room, if the fire alarm sounds, please leave the building by the nearest exit and make your way to the fire assembly point in the car park. The agenda papers and other relevant information for this meeting are available for public viewing on the Herefordshire Council website. The Council is streaming this meeting live on the Herefordshire Council YouTube channel and is making a recording. Others are permitted to film, photograph and record public meetings, providing that it does not disrupt the business of the meeting. There are no members of public present at the moment. For participants in the room, please raise your hand to indicate that you wish to contribute. When invited to speak, press the button on the right of the microphone unit and speak directly towards the microphone. Please remember to turn your microphone off once you've finished speaking. Please ensure that mobile phones, laptops and other devices are turned to silent. For participants in attendance remotely, no, we haven't got any, so I'll skip that. So item 1 on our agenda today is apologies for absence.
No apologies for absence received, Chair.
Thank you. But I do note there is one committee member absent without apology. We have no named substitutes, and we go to item 3, which is declarations of interest. Do any members wish to declare any interest on any agenda item? No members. The minutes document for the meeting held on the 27th of October 2025 is included in the agenda pack, page 11 to 14. No matters of accuracy have been notified to the monitoring officer. Are you content that I sign the minutes as an accurate record?
Yes.
Thank you. Item 5 is questions from members of the public, and this committee has not received any questions on this occasion. And 6 is questions from members of the council. And again, sadly, the committee has not received any questions on this occasion. So now we move on swiftly, actually, to item 7, which is Health Watch Herefordshire. And the purpose is for the committee to receive an overview of Herefordshire Health Watch and its work, the government proposals to abolish Health Watch England and Local Health Watch, and principles for future delivery of Health Watch's function. We have with us today Christine Price, who's the Chief Officer for Herefordshire. Oh, I keep saying it the wrong way round. Health Watch Herefordshire, not Herefordshire Health Watch. So I'd like to welcome Christine.
Thank you, Chair. You'll have all received a report that I've written which provides some background on why Health Watch was created in 2013 and the national picture in terms of what Health Watches were set up to do, and some local context around how that's been delivered since 2013 in Herefordshire. I'll take that bit as read and I'm happy to answer questions on it, but I think the bit of the report that we should perhaps focus on is the current national position of the government proposals and some of the work of Health Watch England and the Health Watch network around preparing for the future. So the changes that the government announced back in the summer came about as a result of a penny dash review about patient safety, and it included looking at a whole range of different bodies and functions that exist across health and care, and Health Watch England and Local Health Watch were included as part of that review. So I think the thinking from government as part of that review was that they wanted to streamline processes around patient safety broadly, but particularly in this context, patient feedback. And their thinking was to abolish Local Health Watch and Health Watch England and to create a national department of patient experience within the Department of Health and Social Care, and then locally to give responsibilities for a future function similar to Healthwatch, and I'll come back to that in a minute, to separately to ICBs and local authority. So the Integrated Care Board would be responsible for the function around NHS services, and then the local authority responsible for the function for social care. So we've been waiting for more information than that, and I know we've been in dialogue about, is there any more information? There isn't really very much more concrete information. As a network, we've had a number of webinars with the Department of Health and Social Care that are looking at this. There's a working group in the department leading on all of the different reforms related to the Penny Dash review. And there's a piece of work that they've commissioned the King's Fund to do to look at the future function and what it should and shouldn't include. So far, all we know that is they want it to be patient experience. They want it to focus on harnessing digital and the NHS app. And they've kind of answered some questions that we've all asked and not others. So we don't know whether or not there'll be any application of the transfer of undertakings of proceedings for employment for staff in health watches into future functions. So that question hasn't been answered. Historically, since 1974, every time there's a patient experience function that changes to another name, that has applied, but we don't know yet if it will in this case. We don't know if the current funding allocated to Healthwatch England or Local Healthwatch will still remain, increase or decrease or go altogether. So currently the money that funds Healthwatch locally comes to local authorities from the government, and the local authority commissions that function based on a set of nationally agreed criteria in the Health and Social Care Act. So until we know more about what the future functions are going to be that ICBs and local authorities are going to be asked to deliver, it's pretty hard to really come up with a plan for how we as Healthwatch can shape and influence those functions to make sure patients and the public have a voice in how they look locally, and whether or not we're part of the future or not. So I think there's lots of people waiting for more information on those kinds of questions. What we have asked questions on is there going to be any flexibility locally for ICBs and local authorities to come together and work on a joint function that meets the criteria when it comes? So far they've said potentially yes, and potentially they could commission a function if they wanted to. But I think it's very difficult to explore any of those opportunities when we don't know the answers around what funding there may or may not be, how specific the function criteria is going to be set by government. So nothing can change until there's a new Act of Parliament that's gone through. So all we know at the moment is there's likely to be a white paper that gives more detail in the new year to Easter. And normally it takes about 12 months from that point for it to become an Act of Parliament. And until then, the Herefordshire Council would still have the obligation to commission Healthwatch as it is at the moment. And there would usually be, as in other transitions like this, a period leading up to the change of the Act where we're preparing for the future one and the old one plays a role in transitioning any required information or planning towards that, whether we're part of it or not. So it kind of will exist until the day the Act changes, and it shouldn't theoretically change drastically in that time because we have to stick to the current legislation. But I think there's just a lot of questions based on specifically what will local authorities and ICBs be asked to do. There's a lot of functions that Local Health Watch have that isn't just about patient experience. So we have a role to provide information and advice, to involve volunteers, to go out and do sort of proactive research in communities, and hold the system to account by being involved in lots of different places across the health and care landscape, committees, boards, health and wellbeing board, all those sorts of functions. So what we don't know is how any of those other things feature in that future spec. So it's kind of a presentation where there's a lot of unanswered questions at this stage. And I'm sure that locally there'd be a lot of commitment to start talking about what the future could look like when we know more. The reality is there might be a scenario where the current funding that exists for Local Health Watch won't exist in the future. So it changes the conversation until we know the answers to a lot of those questions. It might be that the ICB and the local authority are asked to just take up those functions with no extra money, and that's a different conversation again. So, but I guess a lot of it is very hypothetical until there's more detail that comes from government about that. Nationally, as a network, we're coming together quite regularly to try and influence the King's Fund review around what are the principles that make the model of Health Watch work. So what has worked, what hasn't worked, and what can then be suggested going forward for the future function. So things like the independence has been a valuable asset, the local connection to communities and the detailed work, engaging with communities on the ground. So it's thinking about some of those principles and how they could be delivered in the future as part of the new specification that the government put out when they do. Nationally, and I think this is on the page, Health Watch England have done some work with the whole network to bring up a kind of set of principles that they think are what the government need to take into account in planning for the future. I'm scanning it, trying to find the page for you. That one. This one, yeah. So they've come up with, on page 12, they've come up with 5 points that they think are important in what the public would benefit from having around patient voice in the future. And so these are written in a way that isn't about trying to preserve the brand or the current function. It's much more about, well, what has worked and what would we want to see for the future for local residents and across the country. So the being locally driven is really important. I think some of the rationale in the Penny Dash review has raised an issue about the inconsistency across Health Watch across the country, and part of the difficulty around how different local areas have managed to use the local feedback from a Health Watch has varied based on how effective their local Health Watch is. Some of that is related to the capacity and funding, some of it is around skills, and some of it is around their effective relationships with their public sector partners, which is variable in different areas. I think I would say that in Herefordshire, I think we've got a good balance of working well with our system. It hasn't been a very changeable contract, so we've been able to establish relationships and maintain them and work effectively to push public patient and public voice into health and care systems, but that hasn't been the experience everywhere. So I think part of the ambition of Local Health Watch was around localism and being very locally driven, but with that becomes the risk of inconsistency in approach across the country, and that sometimes makes it difficult for patient voice to effectively be fed in the same across everywhere. I think that probably reflects NHS systems more than it does local authorities. I think by and large, I think the relationship between local authorities and health watches seems stronger in most places. But I think there's something about the changeability of the landscape and people in health and care that run statutory services changes quite a lot. And sometimes that's difficult for a small local health watch to keep up with and keep maintaining those relationships. So being locally driven is important because we want to know what local people think, and you need to know what they're thinking about the services that you deliver and the NHS delivers to make sure that you're able to reflect that in the service design and improvement. Some of the other things is around how health watches currently reach out to communities. So there's a recommendation here around the future function, not just relying on being a formal feedback mechanism that's quite transactional about the appointment you've just had or the thing that you've just been and received, but much more proactive and reaching out into communities to get a broader base of feedback. And I think on this, lots of what local health watch hear, what we hear in Herefordshire, it's probably more about pathways and where gaps occur and where things don't go to plan between one service and the next than it is about a transactional response about a particular appointment or a particular episode of care. I think people are generally fairly confident in feeding back about a particular appointment or a particular episode of care. Where it becomes difficult is when they're not necessarily sure they're receiving what they need to receive or that the pathway has worked as well as it could have. And it's difficult to know who to go to with that journey, if you like, and story of feedback across multiple services and trying to navigate what they should do. And I think that's the uniqueness of where we're able to help them. And I think also that ability to feedback without worrying about affecting the service delivery that you're getting directly from a provider. So I think the importance there around reaching into communities in a variety of ways, not just the transactional rate this service on the way out kind of approach. We're also trying to champion that data will only give you part of the story. So that kind of transactional feedback approach, so, you know, good, bad, indifferent, or 1 to 5, or whatever it might be, is only part of the story. And that actually the qualitative stories and testimonial feedback of how things have impacted a patient or service user is really valuable. So it's important to do both. Then number 4 is around patient experiences being made to be central to decision making. I actually think this is probably one of the things that the DASH review is picking out, that isn't consistent everywhere currently with the Health Watch model. Potentially there's a scope with the new legislation if they're hardwiring it into ICBs and local authorities directly. It's within their gift to make it part of the business that they do every day. Lots of people talk about co-production and listening to the public, but I wouldn't say it's done categorically all of the time systematically well. So it's how can the future model hardwire things in so that it has to be taken into account in the delivery and design of everything. And I think that was certainly the ambition of Health Watch when it was brought in, but I think that's one of the areas that still has improvements to be made in the future. And I think the really important thing is about how the system responds to say that they're listening to local feedback. So it matters a lot, the difference that it makes. And if people don't think it's making a difference, they won't do it. So the success of getting the feedback is to complete the loop and to be transparent about what you can and can't do and what you're prepared to change as a result of feedback. So they're the principles that Healthwatch England are working on behalf of the network in terms of influencing the future model. But until we see some legislation, we don't know what the future model is going to look like and what local authorities and ICBs are going to need to do. So at the end of the report, I talk more in specific detail about what it is we do locally, what we as an organisation will continue to do beyond the life of Healthwatch. So we are a broader charity that do a range of things in addition to Healthwatch. We will have to change and adapt without Healthwatch, but some of the other functions will be able to continue some of that activity in sort of charity terms. I guess what I would like to find a way through it is that we can support whatever the future function is, informally or formally, however that works. I would like to be able to keep as much of the local expertise that we've built up within the system in some way, so that we're not losing those local connections that are central to listening to communities. So I guess I can't say how we'll do that until we know more. So it's quite difficult really, and we will have to go through some processes as an organisation as a result of this towards the end of the year next year, when we do know what that transition needs to look like. And I suppose, on page 17 I tried to lay out what it is we can offer, how we would want to work with you and the ICB on the future. But to be honest, it's hard to be more specific about how we could or couldn't do that until we know a little bit more, really. So I'll probably stop there, and it might be easier if you want to ask questions or explore any specific points.
Thank you, Christine. It is such unknown quantities and qualities, isn't it, there? We just don't know what it's going to bring for Herefordshire. And the Penny Dash review recommends simplifying patient voice bodies, which, how on earth do we do that? There's, it's quite a report that she did this year, wasn't it? I know we're only in November, but I'm already in 2026. And it's set every question to people's minds, hasn't it? Sent many questions. I know there's one councillor who's really interested in patient participation groups, and I note you mentioned that in your quarterly report on page 6 and 7, and no doubt she will want to ask some questions on that in a second. But the thing that I was a little disappointed in was the actual data evidence that you've got in that quarter 2 report. It's quite basic and short, and it seems like the most contact you're having is via Facebook and Instagram and areas like that. So do you want to comment on that one?
Yeah, I would say that we're having most contact face-to-face out and about in communities, and I think it would vary quarter to quarter quite vastly. So some quarters we're working on specific topics of projects where we need to be all over the county talking to anyone and everyone. And then other quarters, the projects might be very specific. So at the moment, they are very specific. So we are specifically talking to people with a diagnosed serious mental illness. So, you wouldn't see a lot of visibility of that out and about because we're targeting people with schizophrenia, bipolar disorder, to have very specific conversations one-to-one with those people. And another project we're doing, so there's 3 on the go at the moment, and they're all quite targeted. The second one is We're in the emergency department at the moment, so different days, different times across the week to talk to the public using ED right now about why they're there, what they've tried before they got there, if they've been sent there by a particular clinician or service, to try and understand what's driving the demand in the public's attendance at ED. So we don't want to go out into the general public and just say, what do you think of ED? Because we'll get a broad range of feedback from people who might not have been for the last year or longer, which is, whilst we wouldn't not want to listen to that if people want to tell us those things, we specifically want to know what's happening right now. And that project will be, so we think we're up to about 150 people at the moment that we've spoken to understand what's going on to make them turn up on that particular day. You know, could they have used a different service? Are there problems elsewhere that mean ED's their first choice rather than somewhere else? And is there something we could do there about how we drive people to the right service at the right time as a local healthcare economy? And then following it up, once they've finished that, we'll ring every single one that's consented out of that number back to find out how the whole experience went of ED. So I guess you wouldn't see that out and about. And then the last one at the moment is working alongside people with a neurodiverse diagnosis. So bringing people together for specific focus groups to basically audit a range of community spaces and transport to find out what their views are on the sensory experience, to come up with suggestions for improvement. And that's a project to support the autism strategy at the moment. So all of those projects mean we're going to specific places doing very specific things, rather than other projects where we would have potentially been a very broad brush going out everywhere trying to find anyone that we could talk to. So you're much more visible to the general public in those kinds of scenarios. And I guess there's a range of other things that we would do in terms of, at the moment, we're getting quite a lot of people coming into the new premises that we've rented. So we started to offer face-to-face sessions for coming in to talk to Healthwatch for general information and advice. So we've had quite a busy time in the last few weeks with that, because that's only just opened in October. So I think it varies from quarter to quarter. Sometimes we're out at summer fetes, events, fairs, when you're sort of June, July, August, where we'd see lots of people. We're talking to lots of people, but if you've not got anything specifically to say that they've told you, then you're not recording numbers for the sake of it if they've not given you some feedback or taken part in a particular survey, project, discussion, that sort of thing.
Yeah, I suppose that's the problem with looking at things on a quarterly basis. You're not getting the full picture, and I think that becomes evident in your annual reports. And I think it's really great that you target specific current users so that you're getting the correct data, and it will probably help us in our task and finish group in the future. So yeah, we thank you for that.
Just while we're on this, hello Christine, just we're on this, I do wonder if going forward, to help us play as useful a part as we can in whatever the future may hold, whilst I quote your words, data is only part of the picture, it is part of the picture, and I think the more information we can have, not just about the people who contact you or you contact, but also things about how you are measuring your own success, KPIs, almost self-assessment of the service. The more hard data that we've got will make whatever we might want to do to try and push the cause, will make it easier for us. So I think it doesn't have to be done tomorrow, but I think in the medium future, that I think the more actual hard data we've got to argue your case and to argue for whatever lies ahead will be really useful. Thank you.
And you mentioned the hub. Is that the one in St Peter's Square? Is it Lee's Place?
Yeah, yeah. So during the day, it's not a homeless hub. So we're only opening that 7 days a week in the evenings to serve a homeless community. So during the daytime, we're using it for a range of things. So people can come in, talk to Health Watch. We're hosting training and events there for various Health Watch activities and non-Health Watch activities. Partners coming in to offer drop-ins and other services to the public that might benefit them. So, it's different all the time, I guess. Different days, different things, if that makes sense.
And do Talk Community come in there?
Not yet. I think a number of people have been in relating to our role in the Homeless Forum. So the homeless prevention, 2 workers that are part of Talk Community that do that role. So they've been in. And I think they wanted to understand what it is there that they can signpost people to that can come in for help around homelessness. But I've offered it up to the Community Action Network in the city if they wanted to use it to come and host their meetings.
And I'm pretty sure I remember seeing Hilary and yourself launching the
Homeless
charter
Yeah.
last month.
Yeah.
And that was at Lee's Place, wasn't it? So it's trying to let everybody know that it's there. I don't know whether you can tell us, is it well attended at the moment, or do we
in
still
the
need to
evenings
get
or
it?
daytime? Because
Both?
the evenings are very well attended. I'm not sure. I think it's quite well linked into all of the professionals that would come across homeless individuals and signpost them, and other charities that also might see homeless people in the course of what they do. So we're getting 20 to 30 people every night to come for that. And over the course of a week, last week I looked, and with that being 55 different individuals across the week. So the evenings are fairly well attended, and I think if it went up a lot more than that, I think there's probably something to be looked at, because it probably wouldn't all be homeless people. I would say if the numbers go up more, I think I'd be questioning who it is that's coming in, and whether we should be trying to manage that, because it's there for homeless people for a specific reason, and we don't particularly want to manage the dilemma of it being for a broader cohort of people who are just struggling and are hard up or haven't got enough money to eat and cook and those sorts of things. I think that's not what we're trying to do. We're not trying to be something for everyone. It's very specific for a cohort of people.
So is this run by your engagement officers, or is it volunteers?
No, it's a volunteer-led model.
Volunteers. And it sounds like you've got plenty of volunteers. I think, did I read 70 at the moment?
Yeah, I think we're probably more than that at the moment. Since we've moved, we've had a lot of interest from new people, and sort of bringing on probably another 20 odd volunteers. So it's quite changeable. Some people dip in and out, and some people don't want to do regular. They just come occasionally. So it's a whole mixed bag of variety of volunteers that we're supporting to do that in the evenings.
Well, this potential change is going to affect the local authority and obviously public health in the future, probably. So, Hilary, would you like to say something on this, or Zoe? So, Hilary, if you just say who you are, and then Zoe, please.
Hilary Hall, I'm Corporate Director, Community Wellbeing. I mean, clearly we are tracking whatever developments happen. As Christina's very clearly said, everything is a bit up in the air at the moment. I think as a broad principle, we'd still want to support whatever function needed to be there in order to hear resident voice, be it Health Watch or whatever the new, whatever comes out in the end. But at the moment, it's very much a waiting game, and we are tracking whatever is happening, and we'll respond to that at the time at which we need to.
So yeah, just in terms of what I'd add to that is that it's obviously written through the 10-year health plan. So we know that there has to be some function. We don't have that clarity, as Christine has said, at the moment in terms of what that look like. But we know that that function is really important, and we can't lose that function in terms of that engagement. But also, from my perspective, that that independent engagement as well, to be able to feed in and help shape service delivery. But we obviously await that clarity. And I guess the other point to make is the opportunity through neighbourhood health. We know that we need to make sure at neighbourhood health level that we're doing that community engagement to be able to help shape what service delivery looks like at neighbourhood level as well.
Thank you, Zoe. And for anybody who didn't know, Zoe is the Director for Public Health here. Christine, you wanted to come back in?
Yeah, I think the other thing to bear in mind is we're not the only people that talk to the public. We might have the role to do Health Watch in an independent way, but lots of parts of the health and care economy have their own people that engage with service users and patients in various ways. And one of the things that I would observe is that we're not making the most of that collective intelligence at the moment, and that might be an opportunity in the future. In the future model is you know, how are we looking at everybody's feedback together? Because I think the risk of only looking at feedback from one lens or one avenue means you might not see the whole picture. So I think it's really important how we maximise all of that feedback from the public and an opportunity to engage with the public in a two-way dialogue. And I think, as Zoe's mentioned with neighbourhood health, that's a big part of what we're looking at the moment, to think about, well, what are those ways in to shape what neighbourhood health should look like. At the moment, it's quite top down. It's very, you know, this is what the plan says you need to do, and organisations are figuring that out. But at some point, that it needs to be a two-way dialogue with the public around neighbourhood health. And we won't be the only people that can have those conversations. I think there'll be lots of partners around the table in the local authority and different health bits of the system that can also be having conversations with patients. We're doing quite a lot at the moment with PPGs to try to support them to be stronger and have more impact, because their function is similar to ours, although ours is broader and across all of health and care. What we found is since COVID, although it's mandatory for a general practice to have a patient participation group, only about half are fully functioning and have one that meets. So we're bringing together networks every couple of months of the existing ones to try and develop the shared learning and progress of things that do work across PPGs, and to try and work with the ICB to encourage the practices that are struggling with their PPG and membership to come along and use the support that we're offering. So we've created a toolkit with some of the PPGs for PPGs to use. So it's those sorts of things really that I think there's lots of avenues to, you know, it doesn't all have to be us, but I think we can play a key role in supporting others to do that.
So going back to the ICB and yourselves doing these PPGs, looking at them, is it working well? Is it just starting?
So
whereabouts are you on this journey?
We started the work locally with our PPGs in Herefordshire earlier this year, so I think probably April time. And we've had a few different network meetings. We developed the toolkit that's out there now. The role of the ICB, I think, is more contractual with general practice and it's for them to ask the question of their different practices as to where they are with PPGs. We've given a picture of what our experience is of who is functioning well with their PPGs and where potentially we've struggled to identify a PPG. And I guess that's for them. So I guess that's the kind of way we're working with the ICB. So we're doing the bit with the patient participation groups that are meeting and coming together, and the ones that want to improve and think about how they work more closely with each other. But there's more work, I think, that general practice need to think about where they haven't got a PPG. And some of that is struggling to attract patients that be interested in being part of something like that, which is where I'd hope the toolkit will help, because there's lots in there about ways they can think differently, different approaches to bringing groups of patients together that could provide that function of a PPG. It doesn't have to be the same as all the other PPGs. You don't have to, doesn't have to be a formal meeting with an agenda and a committee. There are other ways, and the toolkit has developed templates and different suggestions for how practices could work with patients to do that. So I guess what we'd like to see going forward, we can support those that are enjoying the opportunity to come together, but we need to encourage those that don't have a functioning PPG to come forward and work with us to, you know, we're happy to help them set them up and that sort of thing. We don't particularly want to be running them in the long run, because that's not the job. The job is to sort of promote the opportunity and encourage and support, and hopefully they will be self-sufficient within the practice.
The worry from me is that the 50% that haven't got a PPG are possibly the ones that need one, because it might be that there are more problems there that we don't know about that are quite strong.
I mean, I'll respond to that. It's a real mixed bag. I think sometimes it's just down to the local population and not really being interested, but I think it's how you ask patients to be involved that makes the difference.
Yeah, and I, for one, who've attended many of your meetings over at the Kindle Centre, really have a great turnout for people who are interested in health and care and wellbeing in Herefordshire. Any questions? Rebecca, Councillor Tully, sorry.
Please, I would love to be called Rebecca. I've absolutely no problem with it whatsoever. Hello, Christine. So I've got a few questions, and I'll go straight to the PPG one first, and then maybe if I can carry on or leave it to somebody else. It's really, really useful to hear what you're talking about, and thank you so much. That in the report you were talking about this kind of continuous qualitative intelligence and all of the stuff that you're gathering, and you're not the only ones who talk to people, and obviously PPGs is one of those things. And I was interested to know how you're measuring that impact of the toolkit, which looks great, really clear. How are you measuring that impact, and how are you my experience has been that even if when they exist, it's actually statutorily they have to exist. Statutorily they don't have to be listened to. So how much are you working together with functioning PPGs to take that continuous qualitative intelligence that they do collect and do something with it? You know, I think that because it's great to hear what you're doing that's more in depth, but you know there is continuous intelligence and the PPGs have it, and I do think that they sometimes feel that they're not listened to by anyone and that's why people don't get involved, you know, because quite often it just feels like they're not. So I wonder what you're doing collaboratively with them and how you're measuring that as impact.
Yeah, so the network of PPGs that do exist that are coming forward, there's a real spectrum, and so some of them are exactly experiencing that they want to do lots of things, they have lots of feedback, they're listening to other patients in their local area and not being heard and not necessarily being taken seriously, and they don't feel that that's having an impact. And some of coming together is to talk to PPGs where it is working better, and they're learning from others about, well, how did that work? And I'll give you an example that the HMG's PPG, and you know, a lot of feedback out there and noise in Hereford Medical Group. They get a lot of noise in the press about patient experience, but as a PPG, it's functioning pretty well, and they've now running it with an autonomous committee that isn't managed by the practice per se, which is a big step forward. They've been involved in recent CQC visits in terms of PPG members feeding back directly to CQC. They are coming up with priorities and pieces of work that they want to do as a PPG that help the practice, and the practice have been very welcoming of joint pieces of work, and so they're looking at the website, they're looking at the online form system, and they've adapted it to have a tile on their clinic form for neurodiverse people. And this is all coming about as a result of the PPG's activity. And that kind of sharing at the network of PPGs has been really well received, because other PPGs are saying, you know, we would love to do this. How have you achieved that? And a lot of it is relational, and how you go about working closely with the practice, trying to think about, well, what can we do that's useful? And it isn't just a moan fest around everything that's wrong with the services. And I think that's really key. And it does put a lot of practices off. You know, they might be having to have a PPG, but do they have to listen to it? Do they have to take it seriously? And the degree to which they do is probably down to how well that relationship functions locally. So I think it's about trying to build the positive relationship between practice and PPG, so that that practices feel that they can hand over some of that power to the PPG to lead their own system. So bringing together different ones with different experiences of that is really helpful. I guess where particular ones are having challenges with certain issues, we can support them with conversations with the practice to try and broker that change in terms of where they might be getting stuck. I think there's a role for the ICB in their contract monitoring with practices, because it is an obligation that they have to fulfil, and ideally we'd want them to be looking at the outcomes that it achieves, not just do you have one and ticking the box, because it's an effective one we're looking for, not just any arrangement. So I suppose that's what we're doing in the network. How do we monitor the impact of the toolkit? We don't yet. We only know if they tell us they're using it, and we're asking the network, are you finding it useful? How are you using it? But what we don't know is it's gone far and wide. If anybody's using it and doesn't come to those networks and isn't telling us, we're not going to know, which is often the case with Healthwatch reports. They get out there, and unless we're chasing up everybody it's gone to, and people share things on, so we don't always know who's seen it, who's had it, third hand, fourth hand, and we're only going to know if they found it useful if they tell us.
Councillor Tillett.
Just specifically, I wanted to pick up on what you've just been saying, particularly as the only councillor here representing a ward in the city, therefore probably the only councillor with very significant number of residents who are with Hereford Medical Group. I think this model that they have moved towards, should we say, of this autonomous PPG, is very much the way to go, and has made a big difference, because in the very early days of HMG, and many of us are very familiar with some of the issues. I'm a patient there myself. The PPG was, in those early days, often seen as part of the problem, not part of the solution, because it was too tightly tied, if you like, to the practice. And some of those very early PPG's meetings that I went to, it was not productive, because those who were most vociferous in their feedback just viewed the PPG almost as a sort of gatekeeper exercise to defend the situation, and that's where I would also sort of say that Health Watch has such an, or indeed its successor, there has to be a sort of independent role, because very early on in those days, sometimes if I had residents come to me with, you know, problems with their practice, and it happens to us all. The benefit of having Health Watch was you're not part of the practice, you're not part of the council, you are independent, and that was really useful. But as I say, the autonomous model for PPGs absolutely seems to me to be the role to go, and it has made such a difference in terms of feedback, specifically within HMG.
Yeah, I agree. I think getting to that point takes work. And I think getting to a point where the practice and the patients are confident in how that works, and or even that it will work, takes a bit of effort and time. That's probably what I would say.
The big practice, it's easier, but even more necessary, isn't it?
Councillor Tully, did you want to come back on that one? I've got more questions. Okay, Councillor Thomas.
Well, thank you for the report. Sort of getting it back to sort of more basics, you give me an example of how Health Watch has changed the local outcome, because you're talking a great deal about theory, and if you want us to fight your corner, we need a few proper examples. So can you sort of give me one?
Yeah, so earlier last year we did a project with people with a learning disability, and we knew from the data that general practice and public health held that not enough people with a learning disability were coming forward for health checks. So we did a project with that community and their carers to try and understand what they knew about a health check, which is a particular set of tests and questions that they go through with a health professional at the general practice, and tried to understand what was preventing them from coming forward for health checks and vaccines, actually, to try and increase the uptake. But to understand how we could increase the uptake and make suggestions, we needed to do the work to ask people what their experiences were. And so part of that was to, first of all, do the engagement work with lots of adults with a learning disability and their families, working with lots of learning disability charities along the way, to gather that information about what they understood about it, what their views were, whether they felt, you know, they may have already engaged with a health check or not, to build that evidence base. So that was step one. And then step two was to then think, okay, they've told us they don't go to a health check because they're scared about what might happen. They don't know what the environment might be like. They want to know what to expect exactly, what the room looks like, what the person might look like, what kinds of questions they would get asked. All sorts of things about, you know, in terms of personal dignity, about getting undressed, and, you know, all sorts of very specific details that, you know, put them off for fear of just not knowing. So basically the next step was to then think about designing some videos with them that address some of those challenges. So we did two different resources where they were actors in the little films, where we played through an example of somebody with a learning disability going for a health check and going for a vaccine, what the letters look like, what it looks like when you turn up, and the kinds of things you'll get asked. And it was in their language, with the level of detail that they wanted answering. And so those resources now are used in general practice when people are being asked to go for a vaccine or a health check. What we don't know yet is, will that increase uptake? So they've been around for, I want to say, 6 months to 12 months. So we would like to see that there'd be an uptake in vaccine and health checks. Whether or not we'll notice that and whether we could say it's because of the videos, I think Zoe might want to comment, but it's quite hard to attribute it to one thing when there could be other factors. But I guess that's one of the ways that, you know, you explore with a particular group of people what the problem is, what the solution is, and try and help them to create that solution that makes a difference. So that's an example of what we might do to make change.
Did you want to say something, Zoe?
Yeah, so just on the back of that, so Christine's right in terms of being able to attribute it to that, but we can look at that trend data and we can carefully monitor where we would expect that to go and then see the impact, hopefully, that's made.
Yeah, that would be good to see, wouldn't it, Councillor Thomas?
Just to come back on that, you say about distribution. Well, I'm reasonably computer literate. I'm obviously involved in the local, where I've never seen any of this. I've never been asked for my opinion. It's never been sent to me by my practice. So how was it got out into the general public?
So these would be sent directly to a person with a learning disability when they're invited for a vaccine or a health check. So they're given the resource either by text or whatever means of practice used to say, this is what you can expect. And so when they're considering whether they will or won't book for that particular thing they've been invited to, they've got a resource there that the practice has given them to look at. So I guess it's aimed directly at the patients with a learning disability and their carers. So you wouldn't see it out there. I mean, it is out there. It's on the tourist website, but it's not really designed for the general public. It's designed for a specific group of patients that get sent that.
So do you actually do that for other groups? Do you do it for, say, care home users or people with mental health or protected characteristics?
Where would you stop, I guess?
Yeah.
And there's only so much capacity we've got. I suppose we responded to that one because it was a very specific challenge that the general practice were having. You know, we're just not getting the people to come. On the mental health one, that is kind of what's driving the project we're doing with people with a serious mental illness at the moment, because the evidence would suggest that people with a diagnosed serious mental illness would have poorer outcomes in their physical health and life expectancy and a whole range of things. So what we are doing that for is to really understand their perspective on how they think their mental illness and coping with that affects their ability to manage their physical health. And we're not presuming that what that might be. There's no real detailed hypothesis till we've heard from people, but I suppose what underpins that is there's a group experiencing some kind of inequality, and we need to speak to them to really understand, well, what is actually going on and what could the solution be, what perhaps would they say the solution might be for that. So until we've finished, we won't know where that leads in terms of, is it a resource, is it a set of principles and recommendations for a particular service in physical health? We don't know yet till we've gathered the feedback.
And have you thought about going into care homes? Because, you know, we've got a fair few in Herefordshire, and that would be a large percentage of the population. And I was just thinking about the enter and view powers that you have. Is that something you could use to do this?
We could, and historically, when we've used enter and view in care homes, it's been really difficult to navigate. It tends to be quite a lengthy bureaucratic process to get the engagement of a care home for us to go in and do that sort of thing. I think it's still seen as a very inspectorial thing to do, even though that's not the purpose. We're not there to inspect at all. We're there to talk to residents and families. And my experience in the past has been they present a certain way because they know you're coming, and it's quite a managed process. And lots of our care homes, it's really difficult unless family members are going to be there to actually have conversations with the residents. A lot of them don't have capacity. You know, you're not going to be able to have a conversation with a lot of them. So it's a lot of time and investment for very little actual tangible feedback. And it's not particularly welcome. I have spent time going to care home managers forums in the past to try and overcome that perception, and it's a tough crowd, I think. And I think the issue we would have is going to enough of them to gather enough information for it to be useful. You know, you might go into a care home and there might be 30 beds, but you might only really be able to have a conversation on the day with 2 or 3 individuals and a family member. And it could have taken you a lot of time to set that up, to go and do it. Yeah, so it's not an easy area to do, and I guess we have limited resource to do work, and it's never been a good use of time in terms of producing the outputs that we'd want to see. But if there are suggestions or ideas about how we could do it better, or do it in partnership where it might be more successful. I know in the past we talked about working with the quality review team in the council. We've never quite cracked that either. So
It's a shame because, like I said, there are a huge number of people in those facilities, isn't there? But I understand the constraints to it, especially why people are in there, and you may need to get some advocates in or their relatives. Did you want to add anything, Hilary, to that or not?
Just to say I'd be happy to broker a conversation with the quality and review team, see what we could do going forward.
That'd be helpful, I think. Councillor Davis.
Thank you, Chair. I'd like to go back to the Hereford Medical Group bit, please, if that's okay. The patient participation group involvement there seems to have set a gold standard, per se, within their construct of the way they engage with the practice and with CQC from the Care Quality Commission from their inspections, and potentially sets a standard that we need to follow for all our patient participation groups. Is this a danger of you putting yourselves out of a job? Because if they're going to integrate with CQC, you're going to find yourselves not having anything to do because it'll be done at ground level where it should be done, potentially. What are your thoughts on that?
yeah, I mean, I'm all for them doing more, and if that puts us out of that bit of the job, I'm happy with that, because they're the people that need to be doing it and leading it. They're the patients. I would love to see 19 absolutely storming PPGs in the county. That'd be great. And you know, if we need to support them or we don't, you know, happy with that. I think the issue is, you know, all the other services still there, hospital, mental health, lots of other things to look at. So I don't think we'd be short of other things to do. But thinking about PPGs and how Hereford Medical Group have worked, they're a particular large practice, having merged 5 practices. They have that ability to have the scale to resource and support their PPG. And I think because they've had a lot of challenges in public perception, they've needed to work harder a PPG and listening to patients and thinking about improvements. So there's probably been more of an incentive for them to get it right than perhaps other practices. You know, we've got some great practices in the county, you know, better access than most areas of the country. I know the public wouldn't believe that, but it's true. And, you know, patient experience wise, lots of fairly good level of feedback when they do the national surveys, and quite a few that are rated good or outstanding. So I think it's all quite relative, and I think some practices might look at the amount of effort and grief supporting a PPG would create and wonder if it was worth it. But I think one of the things that I've talked to the practice manager at HMG about is going to the practice manager forum for Herefordshire to talk about the toolkit and the support that we're offering and the networking, but also from his perspective, how it has worked at HMG from somebody on the inside who has to work with their PPG. It's usually the practice manager's job. From his perspective to other practice managers about how positive that's been for them as an organisation. So that's in motion to do fairly soon together, which I'm hoping will inspire some of those practices who could do more and potentially could work with us on their PPG to do better. But if we get to a point where they're all on board and all doing great, I'd be very happy with that.
Do we get any further feedback from outside organisations that have good practices that will assist us? As in from out you know, within the ICB, so maybe Worcestershire or Coventry or Warwickshire?
At the moment, I haven't been involved in the Coventry and Warwickshire. I don't think they've got that far in terms of bringing together the practice managers across the 4 counties, but I could be wrong about that. But I have been involved in presenting our offer across Herefordshire at the 2 counties. And the response I had back from that was it was mostly Worcestershire PPGs that wanted practices that wanted help from us with their PPG, but of course that's not what we're not here to support Worcestershire, unfortunately. So I think what tends to often help is to showcase where it works well and the positive things and something tangible about, you know, and that's where we thought the toolkit would help. You know, and we produced that with other PPGs. We used a load of different feedback across Healthwatch network in the whole country, where other Healthwatches have done work with their PPGs in their networks to bring it all together into so it isn't just things learnt in Herefordshire. And also there's a national association of PPGs that practices can sign up to. They produce lots of useful information, resources. So there's plenty out there that if practices want the support and the resources to give them guidance, there's plenty of stuff available.
Councillor Tully?
Couple of thoughts on some things that I've heard, and then I'll ask my question. That we're talking about care homes, and I was interested in what you were doing with Lee's Place and how during the day it's one thing, in the evening it's another thing, and it feels like it's a front door. And I'm assuming that kind of project work is intended to create more open spaces for people to share, because obviously the intent is still with Healthwatch, and I think the new organisation, the idea is still, the values are still about being a patient voice and not being a project delivery service. So one thought was around care homes. What does that look like in a care home? You know, what does that look like if that warmth is happening in care home situations, and then those conversations become easier? No idea. I just thought I'd throw it out there. The other thing was to do with, I couldn't see the learning disability work that you've done on your site. So, but I also couldn't find your most recent annual report, and I've just found it as well. So, it could just be me, but you know, it'd be really great to be able to see that, because it seems like it was again, as Councillor Davis said, a gold standard of, you know, ways that things would work. So I was going to ask about Talk Community. So obviously our landscape in Herefordshire involves Talk Community. It's very much a network and has very much overlapping kind of goals, I think, in terms of kind of alleviating pressure on other services and, you know, being across Herefordshire and those kinds of things. And I wondered how much work you've done together and how you've measured, sorry, I'm always banging on about measuring benefits, how you've measured the benefits of it. And because I didn't see much mention of that within your report. So, you know, where are the overlaps with Talk Community? And then for all three of you, my thought is, therefore, what is like the most important thing? You know, if Healthwatch were to go, what is the thing, if you were to distill it down, what is the unique stuff that isn't happening anywhere else? You know, we know people are talking, we know people are feeding back, we know there's also things, but what is the unique stuff that you reckon would be lost if we lost Healthwatch? I'm so sorry, that was lots of things.
All right, I'll try and remember all of the bits of that. So firstly, we started about 2021 jointly hosting the Herefordshire Community Partnership with HVOS and Talk Community. And that was a space to bring together community organisations and groups alongside statutory partners to connect together better, to understand what was going on across different parts of the charitable sector and the public sector, where the opportunities were to maximise that a bit more and work together. So that ran for a while, I want to say up until the end of last year, and things have changed a lot with the reforms coming down the road, and there's going to be a lot more focus on neighbourhood health, and I think that changes what we might do in that space in terms of thinking about more local versions of that. But to be honest, during the time we were doing that, Talk Community set up community action networks, which were a similar thing, but on a very local basis. So Ledbury, Bromyard, you know, have their own network, could come together, and it could be anybody. It could be your food bank, your local PCSO, or charities and different community groups, as well as police and others, coming together to talk about, well, what's happening in our community. You know, so some of it's networking and sharing information so people are better informed about how to work together. And some of it was about what we're hearing from our communities. Is there anything we can do locally to convene and encourage solutions to some of those issues? So we're part of those networks as an organisation in communities alongside lots of others. I think there's a greater role for that to grow in neighbourhood health, thinking about how it does some of that more formally into health development and structures. How are we similar and different? Well, I guess we all recognise that putting communities in the centre of things, listening to them, and sort of thinking about them being the people that design solutions is something Talk Community are all about, and so are we. And there's nothing wrong in having the same ambitions, because I think that's the right ambition we should all have. I think where there's some really distinctly different roles is Talk Community is the council's response to community development, and there's a function there that is the council's way of how they support communities to develop and build capacity in the voluntary sector and those sorts of things on a very practical level, alongside a whole lot of other things that they do, which are household support fund and all the things you would know, which isn't really the Healthwatch function at all. But as we're connected to communities, there's a role for us to make sure we're not missing a trick in joining up where we can share that intelligence where it makes sense. Initially, I don't think Talk Community's function was to be out there being a public voice function per se, but they are going to hear from communities in the work that they do. So which would be similar for other organisations that have some kind of liaison of some sort in different guises. So I think that reflects back to my point earlier around we need to join those things up more so we're maximising that joint intelligence across all of us. And I guess my aspiration would be it shouldn't really matter who's doing it, just that it's getting done and it's useful, and that we're not duplicating where we don't need to. I'm probably waffling a bit, and I don't know if that's answered all of your question, because you were asking, the other question was about care homes, wasn't it?
No, that was just a comment. That was just me
Yeah.
getting involved when I probably shouldn't.
I
But
probably-
the other question, I'll repeat the other question, but I think my response just to what you were saying is, yeah, I totally agree that it shouldn't be. So I guess what I'm after is, Talk Community's been around a while, you've been around a while. How have you not? You said we need to not. So I guess it's kind of just about where's the evidence that those things aren't overlapping and that you are absolutely harnessing that voice, because it sounds like you said you're part of the community action networks. So in your quarterly reports, like what do you share that shows that stuff that's shared in there comes out into Healthwatch, and then you are the voice for the stuff that gets shared, because as we know, you only get certain people coming direct, so that, I guess that's just a thought. You don't feel you have to reply, but
so I guess it depends what the discussion is at a community action network as to what we're talking about, but quite often we'll be saying, we'll be just talking about the whole range of things we've got going on at the moment and what are the opportunities to link with others to make those more successful. So are there people around the table that could help us identify people with a serious mental illness? Are there people who'd be interested in coming with us to A&E? So it's those kinds of things that be very practical solutions. But sometimes a conversation might be about funding, and Talk Community might bring things to the table. That's probably not something that is a lot to do with us, if you know what I mean. So there might be things on the agenda that we would play a part in and things that we wouldn't. Why are we not sharing all our data together better? It's a really good question. I think because it's really difficult. A lot, you've alluded to it, a couple of you, in you're not seeing in our quarterly report all of the things I'm talking about, because they're quite hard to describe without writing tomes of stuff, because it isn't all data driven. And I guess that might also be some of what Talk Community here is, where does it fit? How do they record it? Where do they feed it in? We have talked on a number of occasions with other partners across social prescribing and other roles that are similar. They're out in communities doing this sort of stuff amongst other functions. How do we all make sure we're sharing that in one place? I might be really sneaky and throw Zoe under the bus to sort of elaborate on that, because it requires some capacity and some kind of technology, some way of coordinating those functions. And I definitely think there's a prize to be had to do it. I'm not seeing many other systems across the country that are doing that very well either, to be honest.
Zoe?
Quite happy. I'm not jumping, but so I was going to I'll answer that bit first, but then I was going to say about, I think, the similarities and the differences and how Healthwatch is aligned with the same principles as Talk Community. But first I'll answer the data and the evidence bit as best I can. I think it's really challenging. I'm interested to learn how that's done elsewhere. It is that challenge, isn't it, around, it's hard enough joining up the quantitative data that we have across the system. It's hard enough doing it within one organisation, let alone doing it across multiple organisations. And really, in my brain, that should be quite straightforward, but we know that systems mean that everything gets in the way, and that's incredibly difficult, even when we're just counting things. So when then we talk about the qualitative data, which is so important as well, because it is part of the picture, and I think you need both halves of it to tell the true story. That becomes even more challenging because the way that we collect that, the systems that we do that on, and how we pull that together. Where I'd like to get to is that we would be sat here talking about a joint strategic needs assessment that does that really well, has the qualitative and the quantitative, and uses it to gather all of that patient insight, community insight, and puts that against the quantitative data to tell us the so what does this mean for our communities. We're not there at the moment, and I can't pretend that we're going to get there overnight, but I think having the aspiration of that's where we would like to be, where I could sit here and talk about a joint strategic needs assessment that does that feeds in the Health Watch data, but also what we get from Talk Community, is where I'd want to get to. But I know that that's a long road to go on. So that's that part of it, of the thrown under the bus bit. I guess the other thought I had around the similarities and differences between Talk Community and Health Watch. Christine's also mentioned, how we're aligned in terms of those objectives. But I would say that Talk Community can facilitate some of that at a community level by empowering communities to do things for themselves. So it might be the community action networks in terms of bringing people together to be able to have those conversations. It might be in terms of the funding side of it as well. So it's able to inject that into communities to enable them to do things for themselves. I guess what's really valuable in terms of the Health Watch side of it as it stands at the moment is that independence and being able to advocate and be able to champion for communities and give a voice to it where they may not be in a position to be able to do that or feel that they're in a position to be able to do that at this point in time. And doing that to commissioners of services, be that us as council or be it the ICB. So it feels that it gives that independence and that advocacy role that Talk Community is not in that position to do and isn't set up to do.
Thank you. I was just wondering if there's any plans for a joint local plan with the ICB, the council and Health Watch that sets out the transition protections over the next 12 months. Is there anything being muted between you?
I guess not yet, and that's not nobody's willing. I think it's just that we don't know what we're being told yet, and it might be articulated in a way that it's not appropriate for us to be involved. It might be articulated in a way that gives a lot of permission locally for Hilary and her teams and people in the ICB to design something quite locally appropriate. And I guess until they release that, nobody knows what to do about those conversations. Other areas are coming together and having some. Lots of areas aren't because they're similar to us. They're kind of, well, let's wait and see what the parameters are first. And some areas are saying, well, we know these are the principles we want together and this is what we would want. But, something might get dropped in from government that makes that a waste of time or not possible. And, it's really difficult to start to have a conversation about, you could waste a lot of time on all the endless possibilities when there might be some facts that come down that discount a lot of things. Is probably what I would say.
Christine, I expect you're aware that at the end of this meeting, the committee will decide on recommendations that they may wish to put to the council. And I think it is quite likely that we might come up with a recommendation that the Chief Exec and the Council Leader should write to the Secretary of State, at least requesting as much pause as possible on this process while we have a chance to assess the ways of mitigating the changes. And it's really, in a way, picking up Councillor Tully's initial question, which, Zoe, you went some way toward, to help us fire that recommendation. I think we need to know, if Health Watch was cancelled tomorrow, what is at risk? What will not be picked up by others? What What are your unique selling points? What is at risk when we lose you? Now, I think Zoe helped when she talked about independence and advocacy. I just wonder if there's any other weapons you want to add to our toolkit.
Yeah, so whether you could say this is unique to us, I don't know, but we do offer people information and advice, and we give a lot of that. And it's often about how to navigate systems and organisations. And I'm not sure there are many organisations that would have that helicopter view across health and social care that can give people independent advice that they could trust. So I think that's what you would lose immediately. There's plenty of places that would give bits of advice about lots of different things. But, you know, when somebody's trying to navigate a life change, some difficult circumstances with their family, that's when they'll come to us because it's overwhelming and they can't figure out how they navigate health and social care services when it's often a myriad of different organisations involved in their care. And I was given a story on Friday about somebody whose brother has been diagnosed with motor neuron disease, and they were trying to sort out the rapidly changing care for their person to stay at home. And on one day they had 28 different interventions, from phone calls to visits to appointments online, trying to sort out equipment, trying to sort out therapies, a whole range of things. And they found it completely overwhelming as to how to cut through all that and figure out what should happen, what shouldn't have happened, what to do about the things that they didn't think were quite right. And it's often a sounding board to work out what my rights are. You know, when things, actually that's just how things go and it'll pan out and it'll be okay, or when to do something about something. And I think that's the USP often, is helping a family to navigate that kind of challenging situation without worrying how it's going to impact on any of their services that they receive. We all know that, you know, it shouldn't impact a service, complaining to a service or querying something, but people don't feel confident about that. So that's often why they seek something independent before they might come direct to a service. And sometimes we would then broker the conversation directly with that service because really, you know, we can't jump in and fix it. We would have to work on their behalf with the organisations that can fix things. So I think that for me is the one. The other is where we work with very specific communities, really gaining trust over a long period of time to understand what the issues are. And it's often around inequalities to do with different cohorts. So I guess we do quite a lot with the learning disability community, bringing together Hear Our Voices and things like that. Then there's sort of work with Gypsy Roma travellers. That's been quite a prominent feature in the last 12 months or more. And there are people who work with those communities on specific things. But I suppose we go in to sort of listen to them, understand what they need, reflect that back to organisations who might be able to do something about it. And I guess people aren't always coming at these different marginalised communities with that purpose in mind. They come at it from their own service rationale. So they're there to deliver, I don't know, a housing solution, a finance solution, benefits, whatever it might be. And they're not able to consider everything all of the time. So it's hearing that holistic view from some communities who won't get heard otherwise. And I suppose that's really at the essence of why Lee's Place came about. Whilst that isn't a Healthwatch project, it's been invaluable for Healthwatch to, you know, I spend my evenings there, so that's my off-duty job, if you like, volunteering there and listening to people's stories. And, you know, I'm on the safeguarding board, I come to the health and wellbeing board, strategy development things, and then chairing the homeless forum. So I'm hearing the theory around how everything works, but then I'm hearing, sitting with an individual, and before we had Lee's Place, we'd always try and do our best to work with homeless people. But they're not an easy group to gain the trust of, because why would they want to talk to me when they're not getting anything in return and their lives are in a difficult spot? Whereas now they will talk to us, and we are able to sit and do engagement in Lee's Place as Health Watch, and use that opportunity for Health Watch to then use those stories to reflect back. It might not be working quite how we think it should, and it's not playing out like that in people's lives, which I think we wouldn't have known otherwise. And I think that's what's really useful. And it's not to have a stick to beat anyone with at all. It's how we then use that with our partners to bring about the right changes together, and how we just improve the way we collaborate to make the services join up a little bit better than they do. And for me, it's those sorts of things that go with Health Watch. As a charity, we'll try and do the things that the charitable side of our organisation wants to do without Health Watch. And so we're not losing some of the gaps, but there'll definitely be things that just won't be our job, without Health Watch.
I think it's a really interesting time, this time of year, that you've opened the Lee's Place, because obviously winter's upon us, and we have got a growing number of homeless people. So I think that support is really going to be beneficial, and it'd be interesting to see what happens over the winter and into next year. Thank you. Any other questions from anybody? No? Okay. Thank you so much, Christine, for coming. And it's a difficult landscape you're on, and we're all on, actually, in these uncertain times. And we will all watch with interest, I'm sure. Did you note any recommendations?
No, none have been received at the moment, Chair.
Did you want to suggest that one?
Well, I certainly think, I know we won't be the first council to do this, that we should request the Chief Exec and the Council Leader write to the Secretary of State asking for a pause in implementation, expressing our concern, and I think in particular, that there are some specific local risks about independence and advocacy and specific communities. If we want to give the examples you've just given of people with learning difficulties, Gypsy Roma travellers, the homeless, but I think we've got to keep it to the forefront of our agenda for sure.
So we're looking for local risk mitigation, basically.
Yeah. I think, could we just spend a bit of time firming those words up? I don't think we can just sort of, with references to this, that, what references exactly do you want on there? And at the moment, you're going to write to the Department of Health and Social Care to request a pause on the consultation, on the implementation. Nothing's actually been suggested that they're going to implement yet. So they've talked about abolishing it, and there'll be a white paper coming shortly, but we have no detail in terms of what actually will happen yet. So I'm not sure what we're writing about yet. So I think it just needs a slight reword.
Okay.
Councillor Tully.
I would totally echo what you said about independence. I feel like that's what we're getting from everybody, that the independence is really important. If the process includes this white paper, I would say that I'm not sure about what a pause brings, in that uncertainty feels really horrible. So I'm not sure that we want a longer uncertainty. But if the next step is a white paper, someone's doing something with that white paper right now, we want to make sure that they know that what this county needs is independence and advocacy and the long-term in-depth work with specific communities. And that feels to me that, I'm sure there's loads of other things, but what I'm getting when you said, if you really could if you really could say, you know, if it went tomorrow, to me, it feels like people are saying that the independence is important, and the work longer term with communities to really understand what their kind of needs are, and innovative work longer term. That's what I would want to be saying to whoever is saying what comes next. What comes next has to have that. Yeah, I'm sure that wasn't clear and concise.
Councillor Thomas.
Yes. There you are, concise. I don't know, basically, what we've really discussed, how we can put a recommendation to our cabinet, because it's not something that cabinet can affect. I think, and I'm sort of, we're going on to our work program afterwards. I think we need to see the white paper, we need to discuss the white paper, and that is the time that we then start to say to cabinet, please represent us and say this, this, this and this.
Councillor Thomas, it wasn't to cabinet, it was to ask the council leader and the chief exec to contact the Secretary of State to ask for a pause on discussion.
Yes, I know, but until such time as we see this white paper, we are in the dark, our leader's in the dark. We really need to see the white paper first.
I think Councillor Thomas makes a fair point. I think if you're asking for a pause, at the moment we don't know what's going to come. So if you want to end the uncertainty, surely you don't want a pause. You want it to come as quickly as possible, so you know what you're working with. So I'm not sure that it's a very helpful recommendation.
And then pause it.
And then, then see what you're going. And then I would suggest you see what's being presented and you scrutinise that. And I think that would give you an indication of what you might be opposing or not opposing or recommending differently to.
Does that sound sensible? Councillor Tully?
So I think my response to what Councillor Tillett said was, I think it's important to be a voice for what has been described locally. I don't know about stable doors and horses in these situations. I guess that if we want to make contact with the people making the decisions about what comes next, that's what I'm suggesting that we do before the white paper.
For what purpose?
So that what comes next has independence and works on a long-term basis with the communities that most need it in Herefordshire.
So that might suggest then a letter that endorses the principles that Healthwatch have suggested in their report. So you could do something along those lines. Healthwatch have given a set of principles. You have scrutinised to some extent those underlying principles. My guess is that you are accepting Healthwatch's arguments about those principles and therefore writing to the leader and the chief executive, because it would have to be an all council letter really. To say that you feel that any future proposals should have those principles as endorsed by Healthwatch at the centre of them. I think that does that sound.
I agree.
I think we can be more specific in that it was, because there's 5, and I mean they all seem great, but what I'm getting is the independence seems really important. So there's a lot of other things in there. And that's what I'm getting. But that's splitting hairs potentially. I'm happy to just say those 5. We endorse what they've said. But I think that the key thing that's coming through is independence.
In that case, I think I got what you're saying. I think rather than have on screen or scribbling over words, this word, that word, might suggest a 10-minute comfort break, let people leave, and we can just discuss those words, just to get it into the right shape. So when we come back on, we can vote on it.
Christine?
Yeah, I was just going to say, it's not for me to say what your recommendation should be at all, but King's Fund are currently doing a review that will feed into the white paper, and the people that will make the decisions about what's in the white paper is the Penny Dash team in the Department of Health and Social Care. The Healthwatch principles, and I think this is Rebecca's point, Healthwatch England have taken the best of Healthwatch and fed them into the principles for a future without Healthwatch, going along with what the government are proposing. So it doesn't emphasise what we want to keep, as in the independence, because it's almost accepting that it won't be independent because the government are putting it back into ICB and local authority. So I guess by just using the Healthwatch England principles, you won't be emphasising that particular point. So I think if you wanted to be thinking about independence, then something in addition to those principles is probably what to do. And I think the timeline is probably quite tight as they're writing this now. So we believe if the white paper is going to come out in the new year.
So looking at the timeline then, committee members, do you think it's reasonable that we should continue with this recommendation? Needs to be done quickly. If
Yes. Oh, gosh.
Well, I think I think if you're at the moment, I think the leader and the chief executive they could write here. We could make this recommendation. I'm not entirely sure though whether that would have to be endorsed by cabinet first, or whether they can just do that in of their own volition.
we could ask, I suppose.
You could, I mean, arguably, you could write it in your own capacity as well, Chair. You don't necessarily need the leader and the chief executive. It's not stopping you writing a letter if you wish to. So you could always do that as well.
Rebecca.
I just wonder if it's the King's Fund that are doing it.
Yeah.
Do we write to them?
There,
Can we
there is
CC people in? Are we allowed to do these things?
there is a guy that you can write to, and I can let you know who that is that's leading on this. They're following quite a methodology. So whether they will accept testimony and influence from people that they haven't already laid out as part of their study is a risk, I guess. It wouldn't hurt to just send them the letter if you sent a letter to the Department of Health and Social Care to send them the same. But I think to only send it to the King's Fund might not land where you want it to.
What I would suggest is I think if you involve the leader and the if you involve the leader and the chief executive, that's going to be a considerably more lengthy process than if you do it yourself. If you do it yourself, we don't need a recommendation. We can just note it as an action. We can draft something. You can agree that. Obviously, I'll speak to the chief executive and the leader to say we're doing this, just so we're not firing off things at random. But you could. My suggestion is you could write a lot faster if you did it yourself.
Are committee members happy with that? Yep.
So in that case, we'll just leave that as an action for now. Great.
Yeah. Okay. Well, that's one way, isn't it? Thank you. Okay. Thank you again, Christine. And it's been an interesting afternoon so far. Thank you.
Thank you, Christine. Comfort break.
Okay. Okay, so I'd like to ask for a short adjournment and the meeting to recommence at 15:55. Thank you. I'm so sorry. Welcome back. We're now going to continue with item 8 on the agenda, which is our work programme for 25-26. Now, we've had an up-to-date version of this. Everybody should have seen it. And Daniel, do you want to say a few words first, please?
Thank you very much, Chair. The work programme is presented to you in your papers. We have also agreed the task and finish group that the committee agreed the terms of reference for earlier this year, meeting the demand for adult social care. The task and finish group work programme is presented in full in the papers. Since this was last presented, we've moved some of the dates along to take account of the delay in finding a chair for the committee, which we've now done. Thank you very much, Councillor Tully. At the moment, the task and finish group work programme extends through to October 2026, and the work programme for the main committee through to July 2026.
Thank you. So, have you all had a look at it? And you're happy with this report? So the committee agree. The recommendation is the committee agree the draft work programme for this committee contained in the work programme report attached, and the committee note the forward plan attached at Appendix 2 and identify any opportunities for collaboration and alignment of work. Can I have a proposer and seconder?
Are we not going to talk about actually changing the work programme to reduce the number of meetings? I thought that was something.
We are down to that, aren't we?
No.
This is still the old model of the number of meetings, isn't it?
We have one, 2, 3. Oh, we've still got 4 for the rest of this year.
Yeah.
Okay.
Well, 4 over the next 6 months.
So what we need to do then is condense those or take out any agenda item that we think we don't need to do within this municipal year. Councillor Tully.
Just wanted to clarify what we mean by committee briefing and committee meeting.
A briefing is an informal information sharing session.
Beforehand.
Okay, so then we've got
Because there's one listed.
we've got a meeting in January and a meeting in March, so just 2 more then. Right before the end of the year.
So first of all, we have not got a committee briefing tomorrow. There is no site visit arranged. Am I correct?
This was in response to an all-members briefing that was shared. Do you remember we had a recommendation that was agreed by the committee?
But it's not been done.
No, it has been. It's been sent out, and it was sent out to all councillors. This is an all-members briefing in response to a committee recommendation that was agreed earlier this year.
But it's not planned for tomorrow.
It is planned for tomorrow. Oh, tomorrow? And it was sent out to all councillors.
So what time is that tomorrow? Because
That's in the afternoon. We only had 4 responses from councillors, and only 2 so far are looking to attend it.
No, nor me.
It was sent out to all councillors, and then who responded to that request to attend? Only 4.
So who's supposed to be attending this apart from 4 councillors?
It doesn't. No one has to attend it, but it was a request for people to attend it. It was an invite.
You as a committee agreed that you would like to do it and it would be a good thing to do, and that since it was such a large piece of work, it would be of interest to all members. So we've extended the invitation to every single elected member, including yourselves.
And only 4 people have shown an interest.
Correct.
So with that in mind, are we suggesting that's a valuable use of time? No. Councillor Tully.
Can I suggest that we agree the meetings and then talk about the briefings, because I now understand the difference, but I think the decision was about how many meetings we were going to have, and I just would like to double check until the end of March, how many meetings would we need to agree to make sure that our task and finish group is adequately resourced? Just a number, how many meetings?
I'm going to throw you back to the scrutiny review of May 2026, where we talked about a different way of working. May 25, sorry, a different way of working. And in the past, what we've done is we've booked a bunch of meetings for you and then said, what do you want to do with all your meetings? And the review argued that this was an ineffective way of using the resource of the council, and that what you should do is you should meet to agree your priorities and then prioritise them according to the capacity that you have. So you agreed earlier this year that the topic of the demand of adult social care was absolutely your most important thing facing the council, and that this committee should track that. And so, and that you also agreed that this was best done through a task and finish group because it was such a large and detailed project that would require detailed work. So we've done that, and we placed that in there, and you agreed that earlier this year. In between meetings, I have approached the committee to say that at the moment your committee there is insufficient capacity to do this piece of work and all of the work that's currently in your work programme. So my challenge to you is this, is that there is insufficient capacity within the officers, both within Scrutiny and within the council more generally, to deliver everything that's in your work programme at the moment. So you're going to have to reprioritise again. Now, you've already stated that you wish to do the task and finish group. Therefore, the rationalisation will have to happen within your committee work programme. So other scrutiny committees have taken this approach, identified the priorities for their work going ahead, up to a maximum of 3 or 4 committee meetings throughout a 12-month period. At the moment, you're still meeting at a rate of once every 2 months and intend to continue to meet at a rate of once every 2 months. That's 6 meetings a year. So I'm telling you there is insufficient capacity for us to deliver that to the standard which we would expect and you would expect. So, at the moment, there are 6, 7, 8 topics on there. I think you need to spend some time to discuss which of those you're going to do and which of those you're not going to do. So you need to prioritise once again.
So, how many meetings by the end of March do we have officer capacity for? How many do we have left?
It's not a question of how much until March. There's a workload over a 12-month period, and that's what I want you to think about, that 12-month period. So
I understand what you want me to think about. I am asking, I just want to know, how many meetings have we all had as the Health Scrutiny Committee across the year so far?
We will have had 6 this year by the end of March.
Right now, how many have we had?
4 then, because there's 2 more to come.
Right. So then we don't really have the capacity in what we're... Right now, how many have we had? 4. So what we're kind of saying is we have used the capacity of the new programmes suggestions.
Yeah. So from end of March, we then have 3 to 4 meetings a year, plus any briefings and your task and finish group. Is that right?
Mm-hmm.
So we go back to them being at best quarterly, which is kind of what we used to do.
Yeah.
It seems to me, looking at the work programme, it's just looking at the work programme as it lies ahead, and this is just a sort of knee-jerk reaction. I think
Up till the end of March.
yeah, 7. The CQC.
Yeah.
It ought to be. Strikes me as the CQC findings are too important for us to not scrutinise, and that may be, in my initial at least impression, is that is our other priority in what exists in the work programme at the moment, but I'm more than happy for others to argue different.
No, I think the January meeting is fine, because we've got the mental health group coming back to share their trust strategy update, and then the CQC, as long as we've got that ready for January. The problem comes when things get pushed back, is like that first topic in January should have come today, but then the report wasn't ready, so we had to push it back to January. So just bear with me a second.
There are two topics in here that you've agreed around the strategy, and the strategy was being presented as a precursor to the other topic, which was around shaping neighbourhood health. This is another priority that the committee have addressed over the years, which is a lack of community understanding or a shared community vision for where services are located and why they're located. In other words, sometimes the public, the community, do not understand why services are located in the places they are. They don't seem to make sense. Why don't we have more working in localities? Why is everything always in the big hospital? Why is so much in Worcestershire? I'm paraphrasing what I hear in the public here, but those sorts of concerns. So you were going to look at a piece of work around how those decisions are made, how they are funded, and how they might work in the future. And that, again, strikes me as quite a big piece of work, quite a meaty piece of work, and one that lends itself perhaps to a task and finish group again. So it also strikes me as an evergreen issue. I've been involved in local government for 20 years now, and they were talking around these topics even then. So I would suggest that there's no particular urgency to that. There will always be concerns around that. So if you wanted to remove some items on here that aren't necessarily a priority but are still important, you might remove those topics and as Councillor Tillett suggested, move to a quarterly meeting structure. So have a meeting in January around the CQC response, have a meeting in April around around any other topic, for example, and take out those more strategic items and save them for another day.
Any committee members' comments on that?
Does that give us capacity to to call meetings at a shorter notice if needed? I mean, I'm just thinking if something happens, if there's an occurrence that we need to,
Well, I mean, you can always do that anyway. So there's always that capacity for, say, for example, if a major policy was to be called in, we would have to have an extra meeting, for example. So we could certainly do that. And there are also there are other ways that you can do scrutiny. You don't necessarily need a committee meeting. For example, Scrutiny Management Board is tasked with itself a piece of work around commercialisation, and that piece of work had to happen very, very quickly because of the budget setting process. It didn't have time to convene a meeting, think about it in terms of reference, devise a work programme, recruit people. By the time we'd done all of that, the budget would have been done and dusted. So without having a meeting, they've agreed to go off and do a piece of work. And you can do that as a committee. You don't have to ask permission of the public to do a piece of work. You can just do it. So if you wanted to do something rapidly, we can absolutely do that. If it needs to be a committee meeting, we can set it up for you if you want to. So, but don't feel that you have to. Don't feel that if we reduce the number of committee meetings that within your work programme going forward, it fetters your ability to do any work. It doesn't.
So again, I'll ask committee members, are you happy to go to quarterly meetings from the next municipal year? Yep.
So in that case, if I present a revised work programme at your next meeting with that in mind, you'll be happy with that?
Yep.
Brilliant.
Could I just ask that the revised work programme comes to us a bit before so we can plan our lives around it, and we bring it to the
Oh,
meeting as well?
you'll have it in the next couple of days. This
Amazing,
is an
thank
easy
you.
job.
Okay, so we're all in agreement with that?
Yep.
Okay. Okay, so we'll leave that one to you, Daniel.
Thank you, Chair.
Well done, thank you. Okay, so after all that, the next meeting is Monday the 26th of January 2026. And I thank you for this afternoon's attendance.
Happy Christmas, everyone.
It's too early for